We repeatedly tried to explain the importance and low risk of the spinal tap. And when the parents they're risking their son's life.
Hopefully they'll come around.
And if they don't?
We do the best that we can. Some things are out of our control.
As a family physician, I will never make someone or force someone to do something. I can't. I shouldn't. It's not my job. But I often struggle when people make choices that I know are going to hurt them. And unfortunately, in medicine, sometimes that's just the case.
What's going on?
We were discussing the options for treating your son.
He already looks better.
He is not. And by refusing the spinal tap, we don't know how to help him.
She's in denial. Denial is something that we often see in medicine. There's a lot of stress, there's a lot of emotion, our cultural beliefs, how we function, all this stuff sort of can sort of drop in a moment's notice when there is something critical happening. Denial is also tough to deal with because sometimes as physicians, we can give everyone or give someone all the information they need, tell them personal stories, really implore them, plead with them, and still sometimes they don't make the decisions that we hope that they would make.
What the hell is this? These are the people from the Pitt shooting that we couldn't save today. We couldn't save them. But we can still save your son. You're an asshole.
Is he an asshole? Do you think that was a low blow, too low of a blow? I think if I asked a room of doctors, I probably would get a mixed response. Some people would say, yeah, that went way too far. Some people might say, no. I mean, he was trying to do what he could to save this child. You know, write in the comments, by the way, because I want to know what you think. I've gone as far as sharing my own personal information, family stories, stories of other patients, obviously in a HIPAA-safe manner from patients from years ago, but been really, 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 really blunt to try to get my point across that if they do or do not do X, Y, and Z that we're talking about, they could die, things could be worse, things could be bad. I know I've done that. I know that I also have pissed some people off in the process. Other people, they have chosen a decision that actually helped their health or the health of their loved one. But I want to know, do you think that this went too far?
Obvious pelvic fracture.
I'm in a lot of pain.
You taking any medications? Any drug allergies?
Am I gonna be okay?
Absolutely.
We got you, Hector.
BP 68/42, pulse 130. I got a 14 gauge in the left AC.
Let me just say, I've said it before, ER docs, these teams, they're rock stars. And as a family doctor, I have so much respect for my colleagues who do this on a daily basis. Literally, rock stars.
Let's go 1-to-1-to-1, red cells, platelets, and plasma. We've got that. Let's place an IJ after the intubation, please.
On it.
Okay, EFAS negative. It's all retroperitoneal. No blood at the meatus. Passifolic.
Hector, you crushed all the bones in your pelvis and you've got some internal bleeding. We need to sedate you to treat you.
Pelvic crush injury, that is obviously a very severe injury. This guy is losing blood internally. He's bleeding internally. So it's an absolute emergency. They mentioned his blood pressure, which was in the 60s. We've talked about this before in my prior analysis of the Pitt. You know, blood pressure in the 60s, that is too low. That's what they're trying to bring up. They're giving him blood because he's losing it internally. They're also giving him IV lines, so intubating him, putting a Foley catheter in. They're working to stabilize him right now, and that is remarkable.
Our shift was over hours ago. You don't want to go home and sleep?
Come on, let's go find a good case.
Yeah. Okay.
Poor thing, she's tired, and rightfully so, right? She's been there all day, and they've had major trauma. She's tired.
TXA?
Gave it.
Stable for CT angiogram?
Not at the moment, no.
Keep transfusing.
The blood bank is still waiting on a delivery unless you have some upstairs.
He doesn't need surgery. He needs interventional radiology to embolize the bleeders.
They don't like unstable patients.
It's a good example of how doctors work together. You know, obviously, it takes a village, and it does in medicine too. I'm family medicine, but I'm always consulting other specialists to help with the cardiac issues of my patients, the dermatological issues of my patients, etc. This is a really good example of that too. We've seen this all throughout the Pitt, as you know, but you know they work as a team here. We work as a team, even in family medicine, as an outpatient. Teamwork makes the dream work, as we say, and I think this is a good example of that.
What the hell? Well, like I'm gonna sleep tonight anyway.
What have you been hearing?
I was screaming and crying. Got a feeling that's gonna stick with me for a while.
Okay, this is a really interesting point, and Obviously, I'm not entirely sure what she means by she's not going to sleep tonight anyway. But one thing I remember when I was a medical student rotating through ER, like my ER rotations, it was such an adrenaline rush. I mean, you'd be at the ER for, I can't remember, I think it was 8, 10, or 12 hours. It's been literally 25 years since I was a medical student. But anyway, the shifts that we did, I remember I would come home and I'd be so amped. Even if I got home, like even if my shift ended at 2 a.m. or whatever, I'd come home and I'd be so amped. Adrenaline, like I would clean the house. I would watch TV until 4 or 5 in the morning. Like I couldn't even settle down. And I don't know if that's what she means. She looks exhausted, but when she says, I don't know if I'm going to sleep tonight anyway, I'm wondering if it has to do with just all the drama from the day. She also mentioned like the hearing of like just what she's hearing. I remember when I was a medical student, I was doing ICU rotations. Even though I did well in ICU, it was emotionally very hard for me. I actually think I became clinically depressed on the rotation, and I remember it was hard seeing patients so sick. It was hard being around so much death. It wasn't the same as the ER or a trauma center, but the ICU is it's different, but it's similar. There's a lot of death. There's a lot of illness. Almost everyone is intubated. There are families coming, visiting their loved ones. They're crying. They're tearful. Sometimes they're angry. It's a lot going on. And I remember I would hear the sound of the ventilators. Boom, 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 boom. I would hear that sound in my sleep when I would go home. It was a really tough time for me. It was one of the things that helped me understand what specialty I needed and wanted to go into and which ones I didn't. It can be emotionally very, very tough.
But this sounds like it's between you and Robbie and above my pay grade. Hell, I'm not even sure I'm ever coming back after I walk out here tonight. Fuck.
What are you talking about?
I'm done. Get too old for this shit.
How many of you have felt like that with your job? I felt like that. Absolutely. I remember very distinct periods of feeling like, I don't know if I can do this anymore. I don't know if I can come back. I don't know if I can do this anymore. And that feeling that she has right there, I know what that feels like. Have you ever felt that way? Write in the comments.
Yes.
How's he doing?
Same.
So he's not getting any worse?
Not at the moment.
Our family physician is making arrangements to move him to West Penn.
Will you excuse me for a second?
Wait a minute. As a family physician, I would not be moving anybody anywhere. The family physician is not rounding on that patient in that hospital, very likely. No, that is not something I would do. I would not insert myself or say, oh, I'm going to transfer him. For me, I can't imagine a situation where that would make sense. Me being a family doctor, being outside of the hospital, not being an ER doc, not being there, not taking care of the patient in the moment, not being right there. No. Mm-mm.
I was never high. I was just treating my own withdrawal symptoms.
Well, you should have done that under the care and supervision of a physician.
With that on my record, I could have my hospital privileges denied whenever I apply for a job.
No, that's not true anymore.
Yes, you can still work and do your thing. Yes, it may require a few more paperwork signages and more hoops that you have to jump through and things like that. But physicians who have had problems, have medical issues, can still work. The biggest thing is that healthcare workers, if you have a substance use issue, or whatever it may be going on, that you get help, that you are honest, and that you do the right thing and take the right steps.
You never heard of second chances?
Here's your second chance. 30-day inpatient treatment program, followed by random urine tests, 50 to 60 a year, followed by mandatory NA meetings 3 to 4 times a week for the first 3 years of a 5-year program.
There's help. But it is important to be honest. There is a right way to do that. And there is a protocol and a process for that to happen.
Dr. King, we want you to do the spinal tap before Flynn gets any worse.
Great. I will meet you in there.
Let me tell you something. Ain't nothing like when a patient changes their mind to accept the medical care that you're recommending because you know it's going to help them save their lives or what have you. There is nothing like that feeling. Yeah.
My friend took her own life. There isn't a day that I don't regret not being able to stop my friend. But there also isn't a day that I'm not grateful I didn't do the same.
I just don't want to be here anymore.
Then let's have you talk to a professional.
I really do think her sharing her personal story and being persistent is what allowed him to open up. You know, we're strangers. So I can understand if a patient, like first time they meet me, second time they meet me, third time they meet me, they're like, okay. But I do believe in building trust and allowing patients to understand that they can trust me and that I want to help. And I think that Santos did that in a really wonderful and beautiful way.
Is it painful? Will he feel it?
Not at all. He's fully sedated.
Enter bevel up. Aim for the umbilicus.
Oh, I felt a pop.
That's the supraspinous ligament. Enter slowly. Next pop is the ligamentum flavum, and you're in.
So that's the lumbar puncture they were doing. I'll never forget the first lumbar puncture I ever saw when I was working in the ER as a third-year medical student. My mind was blown. Unbelievable. And again, these doctors, amazing. I mean, obviously, when we go through medical school and stuff, you learn these things. And in many cases, we get to try different things. I never did a lumbar puncture, never got to try one, didn't try one, being family medicine, and I wasn't in enough acute settings where that happened. I did do central lines and a few other things that I got to do. But yeah, I'll never forget the first time I saw a lumbar puncture. I was like, oh my God. Guys, this is only the first half of episode 15 because there is so much. There is more coming. Make sure you subscribe to my channel. Make sure you watch this playlist where I've done Dr. React's videos to many of the episodes of The Pitt, as well as many other shows as well. Subscribe to my channel. Click the little bell for updates. Also, follow me on Facebook. I'm on TikTok, Instagram, LinkedIn, WhatsApp, etc. Guys, I'm Dr. Jen. Oh, sign up for my free health newsletter. All right, guys. Love y'all. Bye.